Good evening to one and all present here live for this today's program. There's a very special day for us where we'll be having our first international speaker, Professor Geoff Hebbard, who is a director of Gastroenterology and Hepatology at the Royal Melbourne Hospital. Sir holds a PhD in neuromotility sciences and has exceptional number of papers in neuromotility sciences, and video manometry is something Sir has alluded to few of us in India a few months ago at CMC Vellore. So today's topic that he would be taking up is combining tradition and innovation, unpacking video manometry for esophageal motility disorders. So the podium is yours, sir. Honor is ours. It's our privilege to have you here on this podium, sir. The talk would be followed by a Q&A session based on what comes. So thank you, sir. Thank you for accepting our invitation. I would also like to thank Reddish Talks for giving us this podium and supporting us for organizing such online innovative programs to help the large gastroenterologists who are upcoming with special interest in neuromotility sciences. Thank you.
Okay, so thank you very much, and thank you for asking me to speak. About really what we're going to do is to talk about where video manometry fits into the diagnosis of esophageal motility disorders. So what I'm going to do is I'm going to talk a little bit about the role and some of the limitations of esophageal manometry. Have a think about what other information might be useful in guiding our clinical management of patients. Talk a little bit about what video manometry is, and then what it can add to a standard esophageal manometry in terms of clinical information. I have a few clinical vignettes, and then on a more practical, from a more practical point of view, we'll talk about how video manometry is performed and what you need in order to provide a video manometry service. So if we think about the clinical role of esophageal manometry, we need to decide what we're trying to do when we do a manometry study. And of course, we're really trying to determine a cause for the patient's symptoms to help both the patient and also the doctor who has referred the patient. And there's a variety of symptoms that will be appropriate to look at with esophageal manometry, such as dysphagia, chest pain, regurgitation, and belching. Other reasons why we might do it might be to locate the lower esophageal sphincter prior to a pH study, or to determine how good esophageal motor function is before fundoplication. But what I'm really going to concentrate on is how we could use it to determine a cause for the patient's symptoms. So if we think about what is it when we're doing a study that we'd like to know about esophageal function. And of course, manometry provides us with pressure, but that's really only one aspect of how the esophagus is working. It doesn't really tell us where the bolus is or what it's doing or how it's transiting through the esophagus. It doesn't tell us anything about the anatomy of the esophagus. Really, it gives us some information as we'll come to, but not a comprehensive view. It doesn't tell us about the wall motion that's creating the pressures. It gives us an indirect, but not a very direct measure of resistance to flow. We can't determine wall tension from manometry, even though it's what drives the pressures, and this might come from muscle contraction or from the compliance of the esophageal wall. It doesn't really tell us about the neuromuscular control of the esophagus, which might be either peripheral or central. And it doesn't tell us about the sensory mechanisms and perceptions. So you can see that esophageal manometry really only gives us one aspect of esophageal function, and we draw a lot of inferences about the rest, but it's not really directly measuring those aspects of esophageal function. So why do we record pressure? Well, perhaps the simplest answer is because it's a relatively easy parameter to record, but also because it reflects the forces that drive the intestinal, in this case, the esophageal contents. And this might be due to muscular contractions, it might be due to hydrostatic pressure gradients, and it's responsible for the movement of liquids and solids through the esophagus. We can also use pressure as an indirect measure of resistance. We look at sphincter pressure, and in particular sphincter relaxation. We can also measure pressure gradients across the sphincters or across any form of narrowing, such as a stricture. But it's important that this measurement is made during the movement of intestinal contents, or in this case, esophageal contents, because in order to determine whether a pressure gradient is effective in moving fluid, the fluid needs to be moving. And we're all aware that over the last 20 years or so, technology has really driven esophageal manometry, and we now represent pressure as a colour plot, a colour map against distance in the y-axis along the esophagus and time in the x-axis. What I'm going to do with video manometry is add an extra dimension to this. So we still have our plot of time, distance, and pressure. But what we're going to add is a synchronized video image, which is why we call it video manometry, which is going to show us what's happening within the esophagus at that time in terms of the anatomy, the wall motion, and bolus movement. So what can we measure by looking at pressures? So we can measure the positions of anatomical structures, such as the lower and upper esophageal sphincters and the diaphragm. But for example, we can't see a paraesophageal hernia because by definition, the gastroesophageal junction and the smooth muscle sphincter are at the level of the diaphragm. We can measure sphincter pressures, so basal pressures and relaxation, but we can't really determine resistance to flow because we don't know when flow is occurring. We can measure esophageal muscle contraction in terms of its strength, coordination, and duration, but we don't know whether it's effective in moving the bolus through the esophagus. We can measure pressure gradients, but we're not sure if they reflect the resistance because, as I mentioned, we don't know where the fluid is flowing. We can measure aspects of thoracomuscle contraction, thoracoabdominal muscle contraction, such as respiration, coughing, and straining, and perhaps we might try to correlate these with special events such as symptoms such as belching or regurgitation. But we don't know where the gas or fluid is coming from, and we don't know what the mechanism is of the symptoms that the patient is experiencing at the time. So we're all familiar with the manometry protocol for Chicago 4. We have a basal period, water swallows in a primary and a secondary position. And then there are some additional tests that we can do to try to sort out specific aspects of esophageal function. But often we come to the end of this and we really don't understand what has caused the patient's symptoms. And that results in the patients feeling frustrated and perhaps the referring doctors as well. So what are we going to do when manometry alone doesn't provide the answer? This might be because we're having trouble interpreting it, that the manometry itself doesn't fall neatly into a diagnostic category described by Chicago 4. Maybe that it doesn't fit in with or explain the patient's symptoms. Or it might be that we think it might explain the patient's symptoms, but we don't. We need to understand a bit more what the temporal relationship is between what we've observed on the manometry and the symptom and what the mechanism of that might be. So what is video manometry? So really what we're doing with video manometry is a simultaneous esophageal manometry and a barium swallow. And the important thing about these is that they're linked in time. So we know what's happening on the barium swallow at each point in the esophageal manometry. So we have information from both, and we have a precise temporal relationship between the two. And so we can correlate events on the manometry with events on the barium swallow. We can do this in the esophagus or the pharynx, most commonly the esophagus. We can do it for liquids, a bolus or a drink in the way we would with the Chicago 4 protocol. And we can do it with solids, and we tend to use bread. And then we'll try to get the patient to reproduce their symptoms and look to see when they're happening, what's happening on the manometry, what's happening with the bolus. That might be the patient experiencing dysphagia, it might be belching, it might be regurgitation, or it might be discomfort or pain. So what extra information does video manometry give us that manometry alone doesn't? So of course, video manometry, because it incorporates manometry, they both measure pressure. Video manometry, however, can give us a bolus transit, which we can't see on manometry. Video manometry will give us the anatomy of the esophagus in the same way that the barium swallow would. It will show us wall motion, and because it's a video, we get correlation between the wall motion and the pressures. We can use the video manometry to determine when fluid is flowing across the sphincter. So the video manometry and the manometry, or the video and the manometry together, will give us a much better idea of resistance to flow than we would get from just the manometry or just from the barium study. And both of them can give us a correlation with symptoms, but only the video manometry can correlate the symptoms to the bolus transit as well as to the pressures. There are a few other things that we would quite like to measure or know about, but at the moment we don't have good ways of measuring those. So I've got a few clinical vignettes to show you, just to demonstrate some of what we can see on video manometry. Okay, so first of all, we have a normal liquid swallow. And what you'll see here, I'll just stop it for a second there. So here we have the radiology image on the left and the manometry on the right, and a vertical cursor on the manometry that moves through, and the point at which the vertical cursor is correlates to that particular time on the image. So if I let this run, you'll see a swallow coming. You see the barium coming down the esophagus. You see the pressure wave coming down the esophagus and clearing the esophagus. So this is what we'd see with the normal liquid swallow. What you can see is that most of the liquid actually traverses the esophagus before the pressure wave even gets down to the bottom. So this is the same patient, but now drinking as quickly as the patient can. So you can see all of the swallows on the manometry. You can see the liquid coming down. You can see that there are no peristaltic contractions during that. There are a few uncoordinated contractions, but then the patient stops, and a final peristaltic contraction that clears the esophagus. So this is the same as effectively the multiple rapid swallows or the rapid drink challenge. So this is a patient, and when you look at the manometry, you'll see that there's almost no peristalsis visible on the manometry. But when you look at the barium study, you'll see that there is actually peristalsis that traverses the esophagus. And it just went past there, but you can see that there was also a gastric belch which fills the esophagus with air. So you can see here that on the manometry, there's almost no peristalsis, yet on the video, you can see that there was a contraction. I'll just see if I can go back to. Back to that. Doesn't want to. Okay. So this is a patient that we were asked to see who had achalasia, who'd had a study elsewhere, which had shown what appeared to be relaxation of the lower esophageal sphincter. So here you can see that there's been a swallow, and here you can see that the LOS relaxes to a sort of reasonable level with quite a low pressure gradient across the esophagus. So we did the manometry, and here you can see the esophagus, which is somewhat dilated. And the question is, what is the lower esophageal sphincter function? Because on the manometry, it appears that it relaxes to a reasonable degree. So this was the initial swallow that we did. And you can also see the esophagus contains a bit of fluid and saliva. So then we challenged the patient with a drink. And here you can see the drink. So the patient's drinking down. And you can see that as the patient drinks, there is flow across the esophagus, and you can see that there's this little spray of liquid here that we call the squirt sign that indicates that there is a significant pressure gradient. And here you can see it's up to 20 or perhaps 25 millimeters of mercury at times, which is confirming that there is ongoing significant resistance at the lower esophageal sphincter from the manometry and the images taken simultaneously. So even though the sphincter appeared to relax at the time of the regular swallows, when we challenged it with the video manometry, it was clear that there was increased resistance. So this is a patient who had achalasia, who told us that they had a trick for clearing their esophagus. And his trick was that he would drink some Coke, and that would help him to clear his esophagus. And so we thought we would have a look into the mechanism of that. So here you can see the manometry and the video, and you can see he's got quite a bit of food down the bottom of his esophagus, and he's got some more coming in, and his esophagus is quite dilated. And so then we gave him some Coke, and we said, drink the Coke, and you'll see if you concentrate on his esophagus here, you'll see it fill up with gas as he drinks the Coke. There it is. And then he pressurizes, and he manages to clear his esophagus by filling his esophagus up with the gas, and then that applies enough pressure to force the food across his lower esophageal sphincter. So this is a patient who had difficult dysphagia, who had actually had a manometry that hadn't shown very much, and so they were sent along for a study. And if you just wait here, you'll see, just faintly here, you can see the outline of gas, and you'll see that there's liquid at the bottom of that. And so this is actually a paraesophageal hernia. And what you'll see here is fluid that comes down from the swallow and sits here where the lower esophagus is being compressed by the hernia, which then flows across, and you can see that there's not very much resistance. So when the peristalsis arrives, that's enough to push the fluid across. And you can see that this isn't a sliding hernia because the esophagus is coming down here beside the paraesophageal hernia that had not been evident, or at least not appreciated on endoscopy. So this is a case of paraesophageal hernia compressing the lower esophagus and causing the dysphagia. And when we gave this patient some bread, it was actually got stuck to a much greater degree at that level. Fortunately, the patient still had the peristalsis that did manage to clear the esophagus. So this is an example of a patient who had dysphagia, and you can see that they have weak contractions with their swallows, and you can see that associated with that, the solid food sort of sits in the mid-esophagus, and that this bit of peristalsis here is ineffective because the food is still above it. So the patient swallows again, and again, it's a weak contraction. It really doesn't propel the food down the esophagus very much. So we then ask the patient to have a drink of some liquid to see what happens. And you can see that with the liquid and a somewhat better peristaltic contraction, the esophagus largely clears. And this is quite a powerful technique to actually show to the patient, to explain to them why they need to drink some liquid with their food, and to give them an explanation for their symptoms. Okay, so this is an example of a patient who had an EGJ outflow obstruction. Here you can see the pressurization above. This was due to a compression, but because the patient still has peristalsis, the liquid flows across and wouldn't really have been appreciated just on the barium swallow, because it looks as if the liquid goes across quite well, but it's only because there's good peristalsis. Which I'll just run that through again. So you can see on the barium study that it does hold up, but with the peristalsis, it largely clears across. But you can also see that there's quite a significant pressure gradient across the LOS at the same time, indicating that there is an obstructive element to the LOS, and likely a mechanical obstructive. So this is a patient who complained of excessive belching. And what you'll see here is a number of belches, and I'll just stop it there. So just to orient you again, so here's the esophagus, and each of these blue lines here is where there's been a belch. And you'll see that when the cursor gets to the blue line, that you get distension in the esophagus, and you can see that that's coming from above downwards. And when we look at the manometry, you'll see that there's a negative pressure in the thorax due to contraction of the diaphragm, and in this case, the glottis is closed, so the intrathoracic pressure becomes negative. And then there's some straining as the belch happens, but the air just comes down into the esophagus and then gets belched straight back up again. So this is supragastric belching. So here comes one. You can see the esophagus filling up with air from above and then closing from the bottom up as the patient belches. Now, as is typical with these patients, the belching goes on for a little while and then winds down a little bit and stops. And again, this is quite a powerful tool for showing to the patient who often believes that they've got excessive amounts of gas in their stomach and are often reluctant to accept that what they're doing is that they're inducing a belch. And often it's associated with functional dyspepsia because they feel better for a very brief period after they have belched, and that positive reinforcement enhances the behavior. So this is a patient who was sent with dysphagia for solids, who had an endoscopy, but we diagnosed a Schatzki ring that had not been recognised on the endoscopy. So here you can see the Schatzki ring, and here you can see the pressurization above the Schatzki ring as the solid is going through. And we always get the patient, if they have symptoms, to put their hand up to show us where they feel the symptoms. So here we're getting a correlation between the symptoms, the transit, and the pressure. And we were able to send the patient back to the referring doctors to say, no, you need to do an esophageal dilatation to deal with this with this Schatzky ring. So there you can see the pressurization as it pops across. And the patient says the symptoms feel better. So what do you need to do video manometry? So of course you need a mechanism for getting the x-rays, and so we have to have fluoroscopy, and the fluoroscopy itself has to have an accessible image output and an appropriate format. And many fluoroscopy machines will already have this as a standard part, and those that don't, it can be added. And the images can be in a variety of formats. They can be video or S-video images. They can be HDMI images, or they can be SDI images as we get out of endoscopes. We have used the video and the HDMI images in the past. You have to have a device that will capture the images and digitize them and send them to what's called the direct show bus, which is an internal Windows bus, which is where the images go to be captured by the software. It requires a special license for our software. It requires an image acquisition license. Of course, you need a manometry system because we're doing manometry at the same time as the imaging. And you have to have compatible software, and the Trace software is compatible out of the box with this, and this will record and synchronize pressures and images. It still has to be activated for that function, and it will display the synchronized data. So you have to be able to record them together, and then you have to be able to display them back in a way that you can synchronize the manometer, that you can look to see what image is happening at any particular point in the manometry. So a bit of on the other practical side, how do I do video manometry? Well, the most important thing is the patient selection. We can't do a video manometry on everyone. We have relatively limited access because we do ours in radiology. We can do 3 patients a week, so we have to be selective in which patients we do it on. And the most useful patients to do it on are patients who have dysphagia, which is proven to be difficult to diagnose. So that might be where they've had a previous standard manometry, so either with us or or at another hospital that has proven to be non-diagnostic. Or it might be something where we can predict that it's going to be difficult. So in the post-surgical situation, so patients who have dysphagia after a fundoplication, the question is the fundoplication too tight, or is it a problem with esophageal body motility, or perhaps was it unrecognized achalasia causing the symptoms? Or it might be patients who've had achalasia who've been treated who have recurrent symptoms. And the question is, should further treatment be directed at either the lower esophageal sphincter or perhaps in some cases the esophageal body in a type 3 achalasia, or perhaps even a distal esophageal spasm. And then we have a group of patients who have difficult or complex symptoms. And these tend to be patients with symptoms such as belching and regurgitation, where it's important to see. You saw how powerful it was to be able to see the gas on the barium study. And equally with regurgitation, you can determine whether it's coming from the stomach or whether it's intraesophageal regurgitation due to esophageal spasm or retrograde contractions. So here's a picture of me about to do a video manometry. You can see we do them in radiology. So we have our radiology fluoroscopy system. Here you can see the manometry system. But our barium, our esophageal manometry catheter, and the trolley. So because we're doing it in radiology, we do the manometry on the fluoroscopy table, and then with it down flat, and then we stand it upright and do the video manometry. And so here you can see the table is upright. I'm looking up at the screen and giving the patient some barium to swallow, so we can look at it in real time up on the screen. So the procedure, as I mentioned, it's done in radiology, although a C-arm is fine. It just depends on what's available to you. I always do a consultation prior to the study, and that's so that I can tailor the study to the patient's symptoms, so that we're answering the question that the patient and the doctor are asking. We then do a standard esophageal manometry in lying and sitting positions, and then we do the video manometry. And depending on the question that we're answering, we'll always do liquid swallows. Usually do some solid swallows, and we might do things like a rapid drink challenge. And then there's a consultation at the end with an explanation to the patient. Sometimes that happens at the time that the procedure is being done, if we've been able to see on the manometry and see up on the screen, and sometimes we'll show the patients the images directly on the screen to explain to the patient what's going on and what's going in the report that's going back to the doctor who's referred the patient. Now, of course, there are some other technologies that can do similar things, and one of them would be impedance monitoring. So you'd be aware that impedance monitoring detects the presence of fluid by monitoring the resistance between pairs of electrodes along the catheter. This does provide a semi-quantitative measure of fluid volume, not quite as quantitative as we can get from the image on the screen. On the screen with the barium swallow, we can directly visualize transit, whereas on the impedance, we infer transit from the fact that there is fluid and then there isn't. The video manometry gives us much more, of course, idea about anatomy and wall motion, and can differentiate between solid, liquid, and gas, whereas the impedance can differentiate gas, but it can't differentiate solids and liquids. The video manometry is done with the standard manometry catheter, whereas the catheter for impedance is a special catheter that has the impedance electrodes on it, which adds significantly to the expense. In the pharynx, we can see aspiration directly on the barium, whereas we infer aspiration on the impedance monitoring. A downside of the video manometry is that there is a radiation dose which limits how long we can actually take images for, which isn't the case with the impedance monitoring, and both are synchronized in time. So another comparison that you might make is between a video manometry and a barium swallow, or perhaps a barium swallow and a manometry done at separate times. And of course, all of the radiological aspects will be the same, but the video manometry will have the manometry catheter. But the difference is that the video manometry is synchronized in time, so we can see that the relationship between the manometric events and and what's happening in the esophagus. And of course, in a barium swallow on its own, you don't have the manometric events to see. So to summarize, video manometry adds to the information that we get from routine manometry. We get extra information about anatomy, and I showed you a paraesophageal hernia, and I showed you a Schatzky ring. It gives us information about bolus transit of liquids and also solids. It will tell us about wall motion. Because we get the patients to tell us when they have symptoms and indicate that usually with their hand as to where they're feeling the symptoms, we can get a correlation between the symptoms and both the manometry and the transit events. And it's really a value, particularly in difficult clinical situations. So as I mentioned, patients who have failed standard manometry or who have complex and challenging symptoms. And it's a powerful education tool to explain symptoms and management to patients, which is always a very important aspect of our treatment. So thank you very much.
Thank you, sir. An amazing talk where two technologies have been synchronized with time, and so much information is added from what just a manometry can give to us. And the way we can see the anatomy, the flow, and when patient keeps the hands to show the symptoms. So I felt like it gives us more multi-dimensional aspect of what's happening in a patient with dysphagia. The best part was when patient was telling about Coke, and we could explain how Coke actually improved his symptoms or something. I
Mm.
was awestruck. So
Yeah,
uh,
but the patient was very thrilled to see how his Coke worked.
so maybe if for achalasia patients, maybe Coke could play a role in initial part of their disease. I'm
Mm.
not sure, just speculating.
Yeah, yeah. Well, a lot of patients, of course, do work out, particularly with achalasia, do work out specific maneuvers that they can do to clear their esophagus, whether it's, they twist around or put their arms above their head and they work out some mechanism of increasing the intrathoracic pressure. I had another patient who was similar to the Coke man, except that he would swallow gas repeatedly and fill his esophagus up with gas, and then pressurize his thorax, and that would help him to clear his esophagus. So we had a video manometry of that being done. Yeah. So there's lots of interesting things about just even normal esophageal physiology that you see from doing the manometry that helps you to interpret manometry where you don't have the video, because you know what sort of transit you've seen, and you know that even if you're not seeing peristalsis or it's very faint, then that it may be quite visible on the barium. It's just not completely occluding the lumen, and so you don't appreciate it as well. And of course, that can make a bit of a difference when you're just trying to decide whether the patient has achalasia, because they may still have some peristalsis.
So, what kind of contrast is given for the patient to swallow, sir? Any difference in the volume percentage or anything like that?
Yeah, we just use the standard barium, and we make it up and we give 5 or 10 ml boluses, and of course when it's a drink, they just drink the standard strength barium. There was a barium shortage a couple of years ago, and we used gastrographin, which does work. Um, I think the barium is better because it gives better contrast than the gastrographin, but the gastrographin does work. And I think
And
I saw it at CMC using urographin, so that seemed to give a reasonable sort of image.
urographin.
I think that's the IV. I think that was the IV form. But as I said, my preference would be to use barium.
And also, I felt the supragastric belchers, like difficult patients to treat sometimes, and to convince them that
Mm.
they're actually swallowing the air and giving it back up. So, there also to demonstrate that actually the air gets in and the air comes out also plays a good role in this specific subgroup.
Yeah, yeah. I think that the patient education aspect of showing the patient what's going on and showing them when they're getting their symptoms, and the patients can understand the barium better than they can understand the regular manometry, but we can be sure and we can give them a definitive diagnosis, and that of course is the first step towards management, is to get a diagnosis as to what's going on and what the mechanism of the patient's symptoms are. Then we can address the symptoms themselves once we know what the mechanism of the symptoms is.
Uh, do you see any more innovative technologies getting added to the this particular combination of uh, fluoroscopy, that is swallow, and video and manometry?
Yeah, I mean, it would be nice to know other things like, the wall tension. Of course, you know that there's the flip is one of the ways that we can measure that. Um, the flip itself, of course, has some manometry on it, although it works does work in a bit of a different way. Uh, I think it would be interesting to see what a video flip looked like. I've never haven't
I
actually
was curious thing.
actually seen that, but I'm sure that if you put some contrast in the flip balloon, it would be quite an interesting thing to see. Again, giving it, different aspects. I think that other methods of measuring wall tension would be difficult. Another thing that you could look at that would be, I think, interesting would be things like looking at, if you could do an MRI or something at the same time. I think that would be difficult. We do have some patients where we've done an MRI and a manometry at the same time. That was mostly looking at, I did that during my postdoctoral studies, looking at the pylorus, and trying to determine what the pressure gradients were during flow across the pylorus. It's turned out to be very low. Um, the problem with that, of course, is that the manometry machine itself is not MRI compatible, so you have to be very careful having it in an MRI. But the MRI again gives you different information, and something like an anorectal manometry with MRI, I think, could give some very interesting information. So I think there's other imaging modalities and other measurements that could be made at the same time to look at other aspects of correlative physiology.
Cool. So one concern is about radiation.
Hmm.
Like, do you keep recording for all swallows or some specific swallows? Because while we do esophageal manometry, we have lot of processes, different
Yeah,
almost 10 swallows and lot
yeah,
of
yeah,
protocol is
yeah.
there. How
Well,
about recording? Because considering radiation is also something which we want to avoid.
yeah, yeah. So we do the esophageal manometry beforehand, so we know roughly what we're going to see on the manometry. And we do target the symptoms. So we don't do 10 swallows, we'll do 3 swallows, and we're very careful about giving the patient the barium, telling them when to swallow, starting the fluoroscopy as they swallow, and stopping the fluoroscopy when the bolus gets down through the lower esophageal sphincter. So there's usually only, a few seconds per swallow. We do record it at quite a high rate. We use 15 frames per second, so there's a bit more radiation there than if you're using at the standard slower rates, but we do think that it gives better information. Um, and if we're looking for symptoms like the belching, it can be more difficult because obviously you can't just keep doing fluoroscopy, waiting for the patient to wait for them to start or tell you that they feel like they're going to belch, and then we can start the fluoroscopy. And similarly with regurgitation or rumination or something like that, if you're looking at it. With the pharynx, we do 3 or 4 5 ml swallows, 3 or 4 10 ml swallows, and 15, and then some solids. So if you're doing pharyngeal as well, that adds some radiation. And of course, we always tailor it to the type of patient. So if we had a young female who we decided that just on the basis of the manometry itself had achalasia, we wouldn't then go on and do the video manometry. Wouldn't do the fluoroscopy part of it because we'd already made the diagnosis. So if the diagnosis is made, in someone who's, in their 70s or 80s, where the radiation's less likely to be an issue, then we'd be a bit more liberal with the radiation, really focusing on trying to answer the question rather than just minimize the dose of the radiation. So it's always horses for courses, and we, as I said, we don't do a full study. We just try to get some representative images, and typically it will be three liquid swallows and maybe one solid swallow for most patients with, say, dysphagia. And then if we're doing a special thing like, belching or something, then we'll push on, and that will involve a bit more radiation, but we try and target it to the time that the patient has symptoms.
Cool. Professor Geoff, you had mentioned about pharyngeal manometry. Just a few words, like how do you go about it? Is the same catheter just pulled across and then seen? What are the special indications where this is get evolving as an indication for a test? Because we are all used to esophageal, anorectal. To some extent, some centers also do antroduodenal and very rarely even colonic. How about this pharyngeal manometry? Like, what is it, and what are the changes? What do we look for?
Yeah. So we do it as part of the same study. What we do is we pull the manometry catheter back so that the high resolution section of the catheter, which was sitting across the lower esophageal sphincter, is now sitting across the pharynx. So we have usually one channel or maybe two in the upper esophagus, and the rest of the channels sort of come up to the back of the tongue. And then we turn the patient around, and we always do side view images for pharyngeal manometry in the same way that the speech pathologists would. And we'll give the patient 5, 10, 15 ml swallows and a solid bolus. And the things that we're looking for is the strength of the and coordination of the pharyngeal contraction on the manometry itself. So you can see the pharyngeal contraction coming down. We don't, with water perfused manometry, get as good an idea of the actual amplitude of the pressure wave as you would with a solid state manometry, but you do get as good an idea about the onset of the pressure wave, which is probably the most important thing. We look at the upper esophageal sphincter to see what degree it relaxes, and then importantly, what the pressure gradient is across the upper esophageal sphincter as the fluid is flowing. So again, that's where it's useful to have the two together and synchronized, because we want to see fluid moving across the upper esophageal sphincter so that we know that's the true pressure gradient. And what we like to see, if there's, say, a web that's of significance, is that we get higher pressure gradients as we give larger swallows. So the pressure gradient with a 10 ml swallow will be higher than the pressure gradient with a 5 ml swallow, and the pressure gradient with a 15 ml swallow will be higher again. And then because we're doing the imaging, we can see aspiration. And that's actually another reason to use barium, because you're actually better off aspirating barium than you are aspirating gastrographin if you're going to aspirate into your trachea or your lung. So we will look for aspiration. So we'll report on the strength of the pharyngeal contraction, how well it clears the pharynx, what the pressure gradients are across the upper esophageal sphincter, and whether there's any evidence of aspiration or not. So that's roughly what we're looking for with the pharyngeal, and that's mostly done for high dysphagia or occasionally for aspiration sort of symptoms, although most of the swallow safety stuff does go to the speech pathologists. We get some extra information from the manometry in those circumstances.
Okay.
So I can see that there's a couple of questions. So is upper GI endoscopy mandatory beforehand? Well, most of the patients who I see will have had an endoscopy, because an endoscopy is usually the first investigation for dysphagia, certainly prior to manometry. So it's not mandatory, but I would say that pretty much by the time anyone gets to me, particularly for a video manometry, they would certainly have had an endoscopy beforehand, just because that's the way the investigations work. And the other question, how to differentiate achalasia with a low LOS pressure from absent contractility. Yeah. So that's where the barium can be useful, because in the achalasia, you will have hold up of the barium at the lower esophageal sphincter. Whereas just with absent contractility, say in scleroderma esophagus, it will go pretty much straight through into the stomach. So really, with the achalasia, using that to confirm that there is hold up there. Of course, you have to make sure that it's not scleroderma with a stricture or something like that. So that's where information from an endoscopy or perhaps an empiric dilatation would be helpful.
So considering prior to procedures, post procedure, post fundoplication, how a video manometry helps in adding information of why there could be a dysphagia? Can you elucidate on that?
Yeah. So I mean, usually the question is the wrap too tight? That's the usual question. And so we can measure the pressure gradients as the fluids going across, and there is quite a wide range of changes that you see with a functioning fundoplication. But equally, you don't want to be taking down a wrap and something that's where the problem is that the esophagus is not contracting enough to push things through. And also sometimes in those ones, there's a question about, particularly if they didn't have a manometry before they had the fundoplication, is it an achalasia that's been missed? And you can't tell the difference between something that's been a tight wrap for a long time and causing a pseudoachalasia and an achalasia, but at least you can make the diagnosis that something needs to be done to the wrap or the lower esophageal sphincter. So what's the role of multiple rapid swallows and rapid drink challenge in video manometry? So I think that we do them, and you saw that in that patient with what appeared to be relaxation of the LOS, we gave them the drink challenge, and you could see that the liquid did go across, but that the pressure gradients were significantly increased. So again, it's just adding extra information to it. And contraindications, I think it's only really relating to the probably to the radiations. Obviously, pregnancy would be a contraindication, and in young patients, we will do as little screening time as possible, or if we feel we've made the diagnosis without any screening, then cancel the fluoroscopy aspect of the study and just go on the basis of the manometry itself.
Do we need a separate technician? Like if the radiologist suite is where we are doing this, the software and the capacitance to combine both the tests in one place, and then do you interpret at same time, or do you interpret it much later when you are actually going to give the results? These are few of the questions. Do we
Yeah.
have to really dependent on?
Yeah. So it is easier to do with two people, with one person sort of giving the barium and deciding what to do, and the other person controlling the computer, saying when the images are being recorded or not. I have done it myself on my own on occasions. I think those pictures are one of me doing it, but what I tend to do is I tend to forget to turn off the computer recording the images. So we don't irradiate the patient, but I get a whole lot of images of just static barium swallow images, which makes the files very large, unfortunately. So it's not a big problem, but it is easier with two people. and in terms of the interpretation, if it's something that can be interpreted at the time, so I can see the manometry and I can see the images, and if I can make a diagnosis with that, and I'm pretty sure that what I'm eventually going to decide is clear, I'll talk to the patient then. If not, then I'll give them a rough indication. And if they'd like to see the images another time, then I'll organise a separate consultation. Now, I know in India that the practices are a little bit different, and it may be that you look at the images and things on a different computer, and next door, and then have a consultation with the patient. It's just going to be determined pretty much by local practice.
Any
I
more
think
questions?
literature that there isn't really literature on video manometry. I think the literature on the regular manometry, there's quite a number of books and articles and things, but really with manometry, it's one of those things where you have to do it. It's not something that you can learn the basics of it from a book, but it's the actual doing of it, because when you're doing the manometry, you have to pass the catheter, and there can be problems with passing the catheter, and you have to have the techniques for, if you can't get it through the lower esophageal sphincter, recognizing when it's correctly placed or when it's incorrectly placed, moving the catheter around to get the optimal recording. So, and that's all. Those are all things that are much better learnt by doing than by reading about them. Reading about them will give you some information, but it's really the doing is 80% of it, and reading about it is 20% of it. Yeah, no, there's actually not very much written about the video manometry. Although it sounds like a recent thing, it's I think the first ones that I did were were around 2000. So I've been doing it for a long time, and there's a lot of clinical experience with it, but hasn't translated very much into publications.
Okay. I think my chat box doesn't have any more questions. And I think we really had wonderful time talking and listening to your deliberation on this nuanced topic, which is really new. We don't have much data to read on this combination and called as video manometry, sir. So thank you for sharing this podium and knowledge with us on this topic of video manometry. It's a great pleasure, and I also thank all the audience for spending a Sunday evening with us, listening to Sir. Thank you. It's our privilege, sir. Thank you.
Yep. Thank you all very much for coming,
Thank you,
and
sir.
thank you for chairing, and thanks Narayanan. I'm sure if you need any more information about the nuts and bolts of the video manometry, organizing it, then Narayanan and Vignesh can help you out with that.
Thank you.
Thank you, sir.
Thank you, sir.
Okay, great. Okay, right. Bye.
Bye.